I'm going to talk today about this exciting new drug category, that of SGLT2 inhibitors, which you have all heard about. And probably you would agree with me in the end that they are typical drugs that start and end at the kidneys. So the story begins more or less like that. This is something you already know: glucose filtration and reabsorption, normal kidneys, normal GFR, normal people. 180 grams of glucose being filtered every day, and all of that being reabsorbed in the proximal tubule by these co-transporters, SGLT2 and SGLT1. So in diabetes, where we have more glucose filtered, the kidney takes a signal that it must reabsorb this valuable substance. So what happens is an increase in the protein expression of SGLT2 and GLUT. GLUT transporters are on the basal side of the proximal tubule cells, so that the proximal tubule increases its capacity to reabsorb glucose by 3 or 4 times. But this is not very good for people with diabetes. And now we know that this mechanism is one of the main mechanisms of type 2 diabetes pathophysiology. And we have this drug class, SGLT2 inhibitors. There are lots of them around. A couple more will be marketed or marketed soon, that actually block this action of the kidney. They block SGLT2. They leave about 50 to 60 grams of glucose to get out in the urine, and they are not the strongest, but quite effective anti-diabetic drugs with a lot of advantages that I will talk about in a second. But for us, being nephrologists, their mechanism of action is not that unusual. They just inhibit, if I may say, sodium cotransport, like lots of other drugs that we are very well aware of. So, what about cardiovascular outcomes? 3 years ago, about 3 years ago, there was a major breakthrough in type 2 diabetes. Until then, the outcome studies have been designed. The FDA requires studies to be designed to prove cardiovascular safety, that the new drugs coming in the market are equally safe with the old drugs. But 3 years ago, we have the EMBARK outcome data coming out, and I'm sure you've heard about that. It was the first trial in diabetes ever showing benefit. This is the primary endpoint: death, MI, and stroke being reduced by about 14%. But this was due to a great reduction in all-cause death, 32%. And this was relevant to this reduction in cardiovascular death, and this was mostly sudden death. So that could be relevant to this reduction in incident heart failure. And if you have a look here in the curves, everything was separated in just a couple of weeks. A year after, we had canagliflozin, the CANVAS program. This actually is 2 studies in one. Exactly the same primary outcome, exactly the same reduction. Smaller reductions in the individual components, but the same reduction here, heart failure hospitalization, and here, primary renal outcome, which I will talk in a few minutes. So we have 2 trials showing cardioprotection with this class of agents. And after these trials were published, there was a huge discussion in the literature about what was going on, how this could happen. A lot of people, different hypotheses, some of them quite strong, some of them a bit cloudy. And there were some exciting new mechanisms proposed. For example, this one that was posed by some seminal diabetologists, that with the use of these drugs, the glucose utilization is actually turned to a higher production and an increase in ketone bodies like beta-hydroxybutyrate, which is a better fuel for the human heart. So this could probably lead to better tissue delivery and better heart function. However, this is not actually very, very clear because, for example, in diabetes, the heart doesn't use glucose, it uses free fatty acids. Actually, it would be locked to use only free fatty acids. In heart failure, heart already uses ketone bodies. And if it's beneficial in heart failure with better oxygen delivery, it should be also beneficial for MI. So very exciting. Some things need to be added in this theory. Another theory that is probably more valid is this. We have now a couple of very good studies showing that both CANA, DAPA, and empagliflozin inhibit, apart from SGLT2, these sodium hydrogen exchange, both in renal tubular cells and in cardiac myocytes. And this is very good because in heart failure myocytes, the intracellular sodium is very increased, partly because of increased action of this pump, and this leads to increased cytosolic calcium, which is not good for your heart. So this is something that is also very exciting, and some work needs to be done. What I'm going to describe in some more detail, however, is what we as clinicians can put our hands on. So this is described by some as the diuretic effect, but I think there are some actions that you would appreciate that could actually improve cardiovascular outcomes. For example, what I believe is very important, blood pressure reduction. So I guess you all know or you've heard that the outcome that is mostly improved with blood pressure reduction is stroke. This is not true. This is wrong. The outcome that is mostly improved from all major seminal trials back 30 years ago is heart failure, is incident heart failure. And we know from UK EDTA that in type 2 diabetes, improvement in blood pressure is much more beneficial than improvement in glucose up to a certain extent. So all these drugs, we know it from different trials, have a specific effect in reducing blood pressure by 5/2 to 3 millimeters of mercury. And we have 24-hour ABPM studies showing exactly the same thing. And EMBAREC was a study with exactly this effect. And if you would like to look for another study with these very, very good blood pressures, similar, and a very similar reduction, you would probably hit the advanced study. So in advanced study, blood pressure moved from 140 to 135 systolic, and this very small drop, of course, this was not a blood pressure study, but this very small drop was also associated with significant reductions in all-cause and cardiovascular death. So at least part of the effect of SGLT2 inhibitors should be associated with this stable, mild but stable blood pressure drop. So, could it be that they are good diuretics? So this is very, very interesting. You all know that type 2 diabetes patients are volume overloaded, and you do know that we need to use diuretics for these patients to control blood pressure. There is, however, a very interesting thing that you perhaps don't know. These are data from the OLHAP, the largest study ever in primary hypertension, where amlodipine, chlorothalidine, and lisinopril were absolutely equal in terms of every outcome studied, with one exception. In diabetes patients, chlorothalidine did better, also against lisinopril, a RAS blocker, in incident heart failure. And this is something we have forgotten. So, with regards to SGLT2s, they combine two diuretic actions. And of course, as proximal tubal diuretics, they should be very, very mild. This is a very mild action. However, there are some situations, like chronic kidney disease with hyperfiltrating kidneys, which I will talk about in a few minutes, that this action could be important. And they also act as osmotic diuretics. Of course, we don't have the quantity of mannitol if you use mannitol for cerebral edema, but yet again, having 60 or 70 grams of glucose every day in the urine is something that you cannot ignore. So you have a mild to moderate, stable diuretic effect. And to prove you that they do act as diuretics, I have this slide from EMBAREC. This is something that a lot of people didn't pay attention. These are outcomes relevant to heart failure, and if you can see here, this is a double-blind study. People didn't know, investigators didn't know what drugs people are on. But in the two EMBA groups, there was a 40% reduction in the need for new diuretics. And this is obviously related to the diuretic action of empagliflozin. So if we really think about what is going on, the diuretics we have today have some important problems. Of course, they are not very helpful in terms of glucose and lipid control. Furosemide has very small duration of action, rebound sodium retention, resistance due to tubular hypertrophy, and a lot of electrolyte disturbances. Professor Rossignol told you about hyperkalemia, but hypokalemia is a major factor also in people with heart failure. And a lot of previous studies suggested that the absence of a beneficial effect with major diuretics was because of hypokalemia in some cases. So these drugs have actually mild or no effects in electrolyte abnormalities. This is again data from EMBARC, where most of the data came from. You can see here sodium, potassium, calcium 0.0. There is no effect. Is this because they're mild? Is this because they act throughout the whole tubule? Well, there could be several hypotheses. And they also reduce uric acid by 1 milligram per deciliter, which is also important. So, could it be RAS inhibition? This is a very, how can I put it, exciting hypothesis. There are no data to support it, but if you can, I'll tell you some things about it later. If you see what happened with RAS inhibition, these are combined data from LIFE, you can see here, and renal, diabetes patients, and of course renal patients have a higher absolute risk. This is here. If you see the curves with RAS blockade, they were separating exactly like what happened in EMBARC. So that actually resembles RAS inhibition. Could it be body fat reduction? Well, I'm not going to talk about advanced heart failure, where people are cachectic, but we all know, this is data from Framingham study, that obesity is an independent risk factor for new onset heart failure. So if you are a diabetic and you lose some weight, and this is not only volume, but it's also fat, then that could be beneficial. And another issue that would be discussed, and I think will be discussed also in this Congress, is anemia. We all know, lots of observational studies, that low hemoglobin in heart failure is associated with all sorts of adverse effects, adverse myocardial remodeling, symptoms, bad functional status, etc. We as nephrologists have experienced the epoidin studies when hemoglobin was going up, but this was not good. But perhaps it was the tool we had to increase hemoglobin. So here we have another tool, and I need to remind you that patients with diabetes in every stage of chronic kidney disease have much more prevalent anemia than patients without diabetes. For example, in 3A stage, if you do a careful matching, you will find that the prevalence of anemia in diabetic patients, due to a number of reasons, including volume overload, is double than CKD patients without anemia. So if you have a drug that actually through volume reduction can help you increase hemoglobin by 1 grams per deciliter on average, you could expect that some people would be greatly benefiting from that. And last but not least, with regards to clinical cardiovascular mechanisms, if I may, could it be delay of chronic kidney disease progression? So if chronic kidney disease, as we know, it is a very potent independent risk factor for cardiovascular outcomes, then if you halt it, it could be very beneficial. So this is, to sum up together, some points for thought with regards to the actions of SGLT2s. So, a couple of years ago, I was giving a lecture like that on a European Society of Cardiology, and I was asking, would we like to see a study with heart outcomes in heart failure? And of course, I was not the only one asking this question, and we now have one study with dapagliflozin and 2 studies with empagliflozin on reduced and preserved ejection fraction going on with these drugs, and we will wait to see the results. So, to go on in what we are mostly interested in, renal outcomes. And there, the situation is, I think, much more clear. So, at first, these are studies with dapagliflozin, nobody was really into kidney because, if you can see here, below 60 mL per minute for DAPA and below 45 for EMBA, there is absolutely no action, zero in glycated hemoglobin. So these drugs are not good as anti-diabetics when GFR is low. And this is something pretty normal. But yet, they managed to send out about 30 grams of glucose, the weight goes down, and we have this very peculiar for diabetologists pattern of GFR drop, an acute drop within days, and then stabilization or improvement, which for you and me is a very familiar pattern from a hemodynamic change that I will talk in a second. Then we had studies like that, animal studies, showing that DAPA prevented mesangial expansion and all sorts of abnormal findings in diabetic nephropathy. And then we have studies on urine albumin excretion, and we had a lot of studies. Of course, most of them urine albumin excretion was not the primary outcome. We recently summarized that, a small effect with normal albuminuria, but if you have micro and macro, there was an effect of about 40% on average on top of RAS blockers. And then we had the other exciting surprise, the renal outcomes from the EMBAREC study. This was the pre-specified renal outcome, and this was a post-hoc outcome, which is actually better, is the outcome we used, doubling of serum creatinine, RRT, or death. The only that's out is microalbuminuria. EMBAREC was not a study of renal patients, but yet it included almost 2,000 patients with GFR below 60 and almost 800 with microalbuminuria. So the renal yield point we commonly use was reduced by 45%. And we cannot help not being excited because if you remember in renal, the number was 16%, and in IDNT, the number was 21%. So this is, to me, important. These are the individual components, and you can also see here that dialysis is reduced in half, which is very, very important. And this is what happened to urine albumin excretion in patients with macroalbuminuria, which is our population of interest, about 50% down and stable on top of a RAS blocker. And almost a year after that, canagliflozin with Canvas, exactly the same effect, 40% reduction in exactly the same outcome. So we have two outcome studies showing the same thing. The only problem is that this was not their primary outcome. So, are there any mechanisms for that? The answer is yes, and the answer lies within the simple proteinuric diabetic kidney disease prototype. You all know about it, starting with vasodilation of the afferent arteriole in diabetes. Of course, angiotensin II plays also a role, but this is perhaps most important. And the only tool we have to delay proteinuria and to reduce proteinuria and delay progression for the last 30 or 40 years is use RAS blockers to increase the diameter of the efferent arteriole. So there was a study. These are the EMBA people, but this is a very good study, a very good science in circulation. Type 1 diabetes, 30 patients hyperfiltrating. The measurements were done during hyperinsulinemic euglycemic clamp, a very difficult experiment. I loved it because it reminded me of my PhD with glitazone some time ago. And after 8 weeks of EMBA treatment, GFR in these type 1 patients, hyperfiltrating, is reduced by 33 mL per minute. And this is coupled by a reduction in renal blood flow measured with para-immunoporate. So if you have GFR drop, a renal blood flow drop, this can only happen through reduction in the diameter of the afferent arteriole. So these drugs actually work in the afferent arteriole. And there is good background data to support the mechanism. This is normal tubuloglomerular function, as you know it. So if you had increased sodium reabsorption here, reduced amount of sodium and chloride goes to macula densa. This is received from the macula desma as a signal of sodium deficit, and it gives the order to the afferent arteriole to dilate. And if you block this effect, actually you will have a blocking of this whole pathway and return of the afferent arterial diameter back to normal. This actually could be also a way to suppress renin, the second mechanism of renal increase, but that's not for now to discuss. So could be other mechanisms also involved? Of course, there could be a lot of mechanisms involved, you name it, from sodium hydrogenase inhibition to drop in uric acid and several other things. But this is, I believe, something that is very, very strong, very, very clear, and it would dominate the other mechanism. So if you put all this together, this is the GFR from Embarek. You can see this pattern, an important dip within a couple of weeks, and then stabilization of the GFR for the whole duration of the study. And if you see placebo here, overall, and I will tell you in a few minutes something that I think is very important, overall, on RAS blockers, placebo did very well, 1.5 mL per minute loss per year. But EMBA did better, 0.3 mL per minute loss per year, and if you stop the drug, the GFR goes up, as you already know, for RAS blockers. So, before closing, just to mention some effects according to GFR. So, do these drugs actually work when GFR is low? Well, as you know, when GFR is low in proteinuric kidney disease, we have single nephron hyperfiltration. So, single nephron GFR goes up, according to this eminent gentleman, Barry Brenner theory. And we had some data coming out like a few months ago. If you see what's going on with glycated hemoglobin, these are data combined from outcome trials. Below 30, zero effect. There is absolutely nothing there, and we already know that. But the effect of weight is more or less similar across GFR categories. And the effect on blood pressure is more potent when GFR is lower. Probably because the relative participation of the proximal tubule in sodium reabsorption, exactly due to hyperfiltration, is larger. And this is also the case for edema. With lower GFR, the difference between EMBA groups and placebo in edema was larger. And if you want to see what is going on with regards to the severity of the disease, red is with empagliflozin, everything is stable, but of course, patients with normal microalbuminuria do more or less quite well. But if you see what is going on with microalbuminuria, this is not an 1.5 mL per year drop in the placebo. They go from 67 to 47. So that is a 5 mL per minute drop per year, and this is something you already know. This is our problem on maximum RAS blockade, and Patrick also told you about that. We have the problems of potassium, we have the problems of resistant hypertension in these patients. This is more or less the best we can do. And if you use EMBA, and this is a lot of patients, and we have to see that carefully, this is double-blind study, this is also stabilized. So, what about the future? The future more or less is here. We had for 30 years large experience with RAS blockade and efferent vasodilation. So these drugs offer us the unique opportunity to work in the afferent arteriole, and actually probably they have some other advantages because they actually reverse the afferent vasodilation, and probably you wouldn't do harm if the afferent arterial works more or less all right, like in neuroalbuminuric kidney disease, but this remains to be seen. So if we ask ourselves, do we need a study with heart renal outcomes? The answer is, of course, we do. The CREDENCE study with canagliflozin was up more or less for 4 years now in diabetic nephropathy. But last year we have dapagliflozin, dapa-CKD in both diabetic and non-diabetic kidney disease. And a few weeks ago there was this announcement that empagliflozin is going to start with Oxford Group a study in diabetic and non-diabetic kidney disease as well. So, to conclude, SGLT2 inhibitors are now a second step treatment. This is not second choice, it's second step after metformin, and we don't know what would happen in a few weeks with the new diabetes guidelines. There are 2 outcome trials, EMBARANG and CANVAS, showing that they reduce cardiovascular events, cardiovascular mortality, and all-cause mortality. We have several mechanisms that we can put our hands on, like blood pressure reduction, diuretics, hemoglobin increase, to explain these effects, and some more exciting background mechanisms. The same 2 trials have shown large reduction in the pre-specified primary renal outcome, reductions in albuminuria and eGFR stabilization. Reversal of afferent vasodilation is the primary mechanism involved, and we now have ongoing trials in both heart failure and chronic kidney disease, and in a few months we would know more about all these things. Thank you very much for your attention.
Thank you very much, Professor Sarafidi. We have 3 minutes for questioning. And while some questions arise from the floor, I was curious about the initial dip on GFR upon starting these drugs, but then there is like a recovery, there is a bouncing back. What are the mechanisms involved?
Well, actually, this is the same thing involved in RAS blocker, only working in the afferent arterial. Again, it's the initial dip we preserve from the drop in the it's the initial dip we preserve when the afferent arterial closes, as I've told, and this actually is also related with the drop in intraglomerular pressure. The good thing that I could hypothesize is that because they do not actually merge with any other mechanism of blood pressure lowering apart from that, and there is also always a specific effect, they wouldn't be so problematic in terms of acute kidney injury. And actually, there are some data I didn't have the time to show from EMBARANG showing that acute kidney injury is also slightly reduced with empagliflozin. So perhaps it's a very, very specific functional effect and nothing more.
Okay, thank you very much. There is a question from the floor.
Thank you very much for an excellent talk. Can I ask you something about the action of SGLT2 inhibitors on the vascular structure and function? Would you like to comment on that?
Well, actually, there could be a lot of things involved. What I know of is 2 studies that have been published on arterial stiffness, and actually they seem to reduce arterial stiffness, which is something, as Professor Lodon would say, very, very, very interesting. There are a couple of background studies suggesting that they reduce hypertrophy of vascular smooth muscle cells, but as far as I'm concerned, I haven't seen anything too large. Any drug that actually gets rid of sodium, either by effects in the total body sodium or by specific effects in the vasculature, would probably be very beneficial. But I'm not sure I have seen something too large. Perhaps it's me not knowing very well the background literature.
We have 2 short questions or answers, one in the front and now in the back.
Okay, thank you. Pantelis, nice comprehensive review. I was wondering if there is any data of the main expected effect of these drugs that would be the reduce of the overload of glucose in the tubular cells and the decrease maybe in inflammation and all the related effects.
Yes, thank you, Jose. This is another mechanism that has been put forward. and it's really obvious. If you have a lower amount of glucose that you have to carry through the proximal tubule, you save energy, and you reduce also micro-inflammatory mechanism within the tubular cells. So it has been also proposed that actually exerts a tubuloprotective property, but there are not a lot of details on that. But this is very reasonable.
Lovely talk. Thank you very much. I just wondered, do you want to say anything about potential role for SGLT2 inhibitors outside the context of diabetes? So they've obviously got lots of potential protective mechanisms. What about the context of IgA nephropathy or other such?
Well, thank you. This is exactly the thing I was trying to talk about in the end of my lecture. At this point, 2 of the 3 major outcome trials have included also patients with non-diabetic nephropathy, proteinuria diabetic nephropathy, and there were some actually key people asking for a separate trial to be done only in IgA nephropathy in the light of the recent trials in IgA nephropathy with failing of the steroids. But you're absolutely right. This is where we get, and as far as I know, the companies would like to be licensed for chronic kidney disease overall, outside the context of diabetic nephropathy.
Okay, thank you very much. And last but not least, my co-chair, Professor Alberto Ortiz, about the albuminuria-clot connection. He would like to answer the question he posed: why do CKD category G2, G1 have an increased cardiovascular risk?
Good morning.